So welcome everyone. Thank you for coming. I found out I was moderating this session, I think 12 hours ago, but thankfully, yeah, I know most of the presenters. Yeah, um, and my hope is that this session, we have some passionate speakers, and I work with most of them. But my hope is that this is interactive, and to some degree, it draws out experiences that you folks have. I don't want to interrupt the flow of any of the presentations, but if I sense that somebody's just itching to say something, I might jump in. Um, the first presentation you can see is on the process that we've gone through developing guidelines in Nova Scotia. And the presenter who's going to present with me is Julie Kaplan. I've worked with Julie now for a few years, and can vouch for her skill at herding cats. It's amazing. Well, she'll go through the process. I don't want to dig into her time. Um, the the sessions that we have, each of them will have a bit of a different theme, but they're all about things that are happening in my home province in our home province of Nova Scotia. See a lot of blue nosers here. So without any other kind of comments, I'm going to get Julie to jump in, and we're going to start the first presentation, Making National Consensus Guidelines Locally Relevant, a Multidisciplinary Approach. Here's Julie.
Thanks, Dave. So we have no disclosures, no conflicts of interest to disclose. So yeah, so just for a little bit of context, here's a map of Nova Scotia, so a small Atlantic province, and we are grateful to be here with you today. Thanks for showing up. And Nova Scotia is also known as Mi'kma'ki, the ancestral land of the Mi'kmaq people. And just for a little bit of context, the population of Nova Scotia just topped 1 million for the first time. So for context, BC is about 5 million, Ontario is 16 million plus. Yeah, I thought that might be a factor. So a small province, so hence sometimes adopting national standards may not be as straightforward as just taking them on. So we're going to share a bit today about the context and background of the work we've been doing in the opioid recovery program at Nova Scotia Health Mental Health and Addictions Program. And we'll tell you a bit about this provincial practice project that we've been working on for the last couple of years and some outcomes and next steps. So there are 23 separate OUD treatment clinics in Nova Scotia. Prior to the start of this project, they all had slightly different names and slightly different approaches to how the work was being done, supporting over 2,000 unique clients. And so folks recognized the opportunity to enhance consistent practice across the province and work towards a provincial program of care. So one of the first steps was coming up with the same name. So the ORP, Opioid Recovery Program, was born, and the PPP, I've thrown in as many acronyms as I can, the Provincial Practice Project was established in 2022 with a steering committee working towards finding those consistent practices. So the steering committee set the tone for the project, including the scope, which incidentally is focused very internally for now. There will hopefully be a second phase of the project where we'll look working with partners like from correctional health, primary health care, emerge departments. But for now, it's really just getting those 23 clinics all on the same page and all the connected providers that support those clinics. And really focusing on evidence-based care and sort of the most recent evidence following with that. So to note, this is a work in progress. So the project is ongoing. The first phase is expected to wrap up around next June. So this presentation today is really based on our experience so far and how we've pulled together different folks from different disciplines to steer this project. Wrong button. Oh, Here's some of the steering committee members. You'll see several of them here at the front of the room. So when we started this project with the intention to be grounded in evidence, it was late in 2022, so we were mostly looking at the CAMH 2021 synthesis of Canadian guidelines for treating OUD and the 2022 Provider's Guide to Treatment. But then as we worked through the needs assessments, that's what we kind of based the needs assessment on to find the greatest variance in practice around the province and identify the main area opportunities for improvement. As we started our work, more evidence evolved. And that's actually a really important element of this project is it's intended to be iterative. So every step of the way, the group was prepared to pivot as new evidence evolved. So in 2023, we started looking more closely at the BC CSU guidelines that launched and Medify as well. We've also been looking at Canada's Choosing Wisely guidelines. The Nova Scotia College of Pharmacists also launched new standards last year, so we were connected with them, making sure everything aligned, looking at guiding documents from regulatory colleges across the country, and certainly CRISM as well. So one of the challenges with most of the guidance coming out of BC and Ontario, it was directly difficult to directly implement some of the guidelines. We have a different population with different needs. And so when translating those national guidelines into practice, the initial steering committee had identified some challenges related to geography, available resources, system structure, and governance that all had to be considered before just kind of adopting. So around geography and transportation, many people in Nova Scotia live in rural or remote areas, so this had to be kind of factored into any planning. Transportation's a factor. There's very limited public transit outside of the Halifax area. So if folks, it's a small province, but it's still 300 kilometers from Yarmouth to Halifax. So that's certainly a barrier to treatment for a lot of folks. As probably everywhere, human health, human resources is a challenge. So recruiting to those rural areas is certainly challenging. And physician availability, provider hours at most clinics were limited. And also post-pandemic and during pandemic, there was a lot of leadership turnaround. So again, that kind of different challenges presented there. Oh, forgetting my animations on the slide. So, and of course, there are systems issues as well.
My favorite slide.
Right, systems issues. So in Nova Scotia, the methadone maintenance handbook had retired in 2017. So during the last many years, it's kind of been a bit of a void of very specific guidance for Nova Scotia. So that was something we were trying to rectify. Another sort of systemic issue was the province had just a couple years before the pandemic consolidated provincially. So all these different teams had not really had a chance to firmly establish a provincial program when the pandemic kind of took over everybody's focus. So once we were moving through that, there was a huge appetite to get on the same kind of provincial page. And also, perhaps different than the rest of the country, Nova Scotia has seen a large population growth in recent years. So that's also evolving some of the needs of the population. So these were some things that the steering committee had identified as challenges and how to move through them. So from the needs assessment, they decided to establish two separate working groups. Each group sort of feeds up to that steering committee. One is focused more on ORP processes. I think there's our ORP processes group.
It's an opioid agonist treatment group, working group.
Actually, that's the next one. But thank you.
I think what I was explaining was just ORP may not be familiar acronym to people. It's how we refer to our programs in Nova Scotia. These are OAT programs.
Thank you. Yes, opioid recovery program. I throw the acronyms around. So each of these two working groups are led by one of the managers that's involved with the steering committee. And I should have mentioned this right from the steering committee is multidisciplinary. So we've got our physician lead for addiction medicine and our domain sponsor at the director level, all the managers from each of the geographic zones, interprofessional practice and learning is part of the group, quality improvement is part of the group. So right from the top of the project is intended to be multidisciplinary. So yes, this group that you're seeing on the screen, they're focused more on the internal processes like forms and client entry pathways and that sort of thing. And then the other group is mostly made up of providers and pharmacists, NPs, physicians, some staff, ORP staff, team leads and managers. And the second group, which I think is on the next slide, they're more looking at the OAT guidelines, so the specific medication guidelines. And that's more the focus of today's project. There's a few of the folks from that group. And I think this is where I'm going to pass it off to Dr. Martel.
Not supposed to touch the mic. So how many of you guys saw these pictures? How many of you have teams that big doing all of this work? Right? Show of hands. Hopefully some. Fantastic. Yeah. Part of my fear when we look across the country is that people come to these talks and some of the questions that come out are things like, how did you find all those people to like, who pays them to do this work? And people, especially working in smaller centers, really have no support. They're doing it all by themselves. And, you know, I joked about herding cats, but we have cats to herd, which is fantastic. So this consensus process is quite remarkable for us to go through. We tried to see what we were going to prioritize when we developed guidelines. And as Julie had mentioned, it had been 7 years since our regulator abandoned responsibility for making or maintaining guidelines. So there had been a big void. But I found that even the conversations about what to prioritize really helped the community itself to gel, to find out what was important, to connect with each other, in addition to figuring out what to focus on. And these are the ones that were of interest. Some of them had to do with care, a lot of them to do with specifics of prescribing or drug testing, but most of them were process issues, treatment agreements that some were even kind of suggesting we should just get rid of. Like, I don't know about your regulator, but my regulator wouldn't like that very much. But if they don't make guidelines, I guess they have to rely on the community of practice to decide what a standard is. And we focus some of our efforts on slow release oral morphine. And some of the big challenge with this is in a wide swath of the province, almost nobody had any experience prescribing slow release oral morphine or morphine. People were even just spelling out the acronym. They hadn't really spoken it before. This is our working group. We had a lot of fun that day. We had little voting cards to try to get consensus. I thought that was quite novel. And I think that's one of the ways that this was so successful, was that a lot of it was a social experience, that the community itself hadn't really shared a lot of space over the years, didn't really, apart from knowing each other's names, didn't really know each other all that well. So being in person and around that table, sorting it out was meaningful and making it fun. We also were looking ahead to try to see, well, what else might we work on next? And this was exciting to me because it said, okay, well, we've done one piece of it. Let's keep doing it. It was momentum. It was excitement. And these are some of the things that came up. When Julie showed a slide that added 2 documents that got published when we started, my only thought was, this could be an endless project. These are coming out constantly. And what happens when one conflicts with the next one? How do you decide which one to take advice from or to base your guidelines on? But that's, to me, the fun is in the debate and the negotiation and the discussion, the conversation about it. One of the big glaring omissions, though, was we chose to do slow release oral morphine first because it was a recognized void, but without first establishing ground rules for standard methadone treatment and deciding about not just fidelity, but we figured we really have to focus on how we operate with methadone, um, as a priority. So that kind of gives you a flavor for our process and the people involved. And this is just the beginning. We hope that this is something that continues to be supported into the future. I want to open it up to questions, conversations. We have a few minutes between talks, and because the talks are quite maybe a little bit different one to the next, I think it's important that we pause and take questions if there are any right now, or if you'd just like to share your experience of where you are in the journey of policy development and consensus building. I was taught by psychiatrists to practice my pregnant pause, and I'm still working on it.
I'll share an experience.
Oh, share it with a mic.
I'm probably loud. Hi, I'm Jessica. I'll say that I actually work for Nova Scotia Health, and so I've been adopting some of these new changes. But I'm just 6 years into practice, and so I have basically begun practicing during that void up till now. And so it's been really helpful and confidence building and team building to know that you're on the same page, like with your peers, or to be able to ask questions like when things come up. And so it's actually been really helpful from a newer practitioner's perspective, to have these new kind of guidelines to go by. And so I just wanted to say thank you, and I'm excited to see where they come next.
Yeah, I really saw that engagement from people in early career was heartening. The other, I think the thing that surprised me too was there were those same apprehensions and at times imposter syndrome among people who'd been doing this work for many, many years, that they had been kind of sitting with tension. Am I doing this right? Should I be doing this? What are others doing? Kind of working in a void, and it really helped kind of boost their confidence or validate what they were doing. Please.
Do you have any advice on building consensus around individual physician practices, and when they disagree, how do we come to consensus? I work at a fairly large hospital with multiple physicians, and even just trying to do order sets for basic day-to-day care, getting them to agree on certain protocols has been very challenging. To try and think of doing that on a provincial level seems incredibly overwhelming. So any advice on how to get physicians all in agreement on what sort of standards or what sort of practice standards they want to move forward?
I'd say lock them in a room with a piece of paper until they come up with something they agree on. But I'm going to defer to Julie because she is the cat herding expert. She'll probably tell you, I don't know, like we all get along in Nova Scotia. Good luck with you guys. But Julie, how did you do this?
It's a really excellent question. I think we had, I don't know if we were lucky or, having the managers from each of the teams involved and being able to maybe kind of personally invite some of the physicians to the prescribing group. And what we didn't mention, that kind of the group that was more focused on the guidelines, that had about 10 prescribers involved in it. They didn't always agree on everything. The buprenorphine discussions were a little bit more straightforward, I think, because there wasn't a lot of sort of contentious concerns with prescribing buprenorphine. But having a few prescribers in that group who maybe were a bit more cautious with things or a little bit more on the conservative side, hearing from community pharmacists who were involved in the group, hearing from maybe the more seasoned prescribers, it was interesting to kind of hear them at the start of the series, and we didn't really map it out, but each medication, we had 4 90-minute discussion series at lunchtime, and the group kind of decided when they wanted these lunch discussion series. So they were always very well attended. We always had at least 14, 15 people, and from the beginning of each series, you could tell who was maybe a little bit more apprehensive, and then they'd hear and they'd say, oh, thanks. That's really interesting to hear from the pharmacist perspective. And that was a really nice bonus of this work, that multidisciplinary perspectives were being shared, and it really did seem to kind of, trigger some light bulbs. SROM was a little bit different because there was a lot more apprehension, I think, from some prescribers to get on board, but being part of the discussion helped. We haven't launched the SROM guidelines yet, but what was cool was that group at the end of their 4-week session said, you know what, like, we've offered what we think we can work with from the evidence that we would like to include in our guidelines, but we're not 100% confident. And that group identified about 10 local prescribers who have known expertise, I guess, in SROM. So that picture you saw with the thumbs up pictures, that wasn't the ongoing working group. That was kind of this little workshop of local subject matter experts, where we then brought, here's what the group is thinking, where we want to lean into the evidence, where maybe some of the SROM guidance out of BC might be a little bit too liberal for Nova Scotia. We're kind of in a different place. What do the local prescribers think? And kind of validated it that way. So I think, I don't know, we'll let you know next year, but I think when we launch SROM, because there has been so much kind of evolving conversation around it, I think it will be pretty rooted in evidence and local support that, well, these are the guidelines. So,
And I mentioned about locking them in a room and coming up with you can't come out until you agree on something. But what happens when you do that? Well, it didn't work very well for my parents, but that room, what happened in that room was people found out, like, who are these people who have all this experience? When I struggle, you seem to know everything. Do you mind if I call you? Like, those relationships are what make this successful. And bringing people together is the biggest part of making this work. And to try to do it virtually, yeah, you can do some of it, but I think what made it most meaningful was that it was in person. The other insight I'll give is, some years ago, like, we struggled, one of the teams I worked in really struggled to come to any decision on anything ever. Like, just everything was just tabled, left the room with resentment, having not decided anything. And a talented facilitator gave us a tool that I spread to other teams. And the tool was, come up with a proposal, no matter how ridiculous, and in the moment, vote on it. And the way to vote was, you're in favor of it, your thumb is up, you're ambivalent, don't know how to think, or you're against it. And then to decide, with that voting mechanism, how do we go forward? And of course, what we decided is, if everybody is ambivalent or in favor, that's enough. It wasn't a majority rules. We were adamant, though, that if anybody had a thumbs down, that was a veto. There had to be some other proposal, or it wasn't going to go forward. That just forced us to decide. So having a mechanism of decision made a difference for us. And the strange part, maybe Amanda can give you some insights, but over time, what happened was people really struggled to vote. And they would think, I don't know how I feel about this. My thumb's not up. My thumb's not completely sideways, so that we started to use a clock. I'm about 10 o'clock, 8 o'clock, but it really forced the question. And consensus is a dance, right? And it's sometimes messy, but having a process really makes a big difference, structuring it. So that's my insight. Other questions?
more comment on consensus building techniques. In Resident Doctors of Canada, having recently been a resident on the board of Resident Doctors of Canada, has something very similar for consensus building to what you guys just described, which is people face to face having discussions and then having basically a Likert scale for voting, and certain numbers above a certain point are vetoes, and we have to go back to, okay, there's clearly, like, they have serious concerns. What do we have to address? Do we have to change the question? Like, we have to break this down all the way to, okay, clearly this is an easy decision for everybody. And I like your guys' more accessible thumbs up, thumbs down.
That sounds somewhat too like, the motivational interviewing technique of, well, how do we bring you from a 4 to a 5? Yeah, but it works. It
That
forces the
is
conversation.
verbatim what the conversation was. Yeah.
Any other questions? Thank you, Julie. That was fun. So this is projecting only partially. What happened to it? No, I know, but it cut off the bottom of it. I think it's just the slide, so we're going to ignore it. Yeah. So our next talk is meet people where they are, the flexibility of a continuum. And it has to do with our model that's in evolution in Nova Scotia, where we're kind of morphing a very historically rigid system into becoming something that is actually more acceptable, more accessible, more equitable to people in the province who require addiction care. And try to advance the slide. And our two presenters, Jessica, that you've heard from, she claims to be like almost as though she's just out of medical school. She's been at this for a time. She knows what she's doing. Don't let her fool you. And Lynn Lowe, who I've worked with quite closely over the past 3 years, pushing the agenda on some of this program development in Nova Scotia. I can't speak highly enough of the work that she's done and the support that she's given. I'm not going to cut in any more to your time, and I'll invite one of you to come up and start sharing knowledge.
Thank you, Dr. Attell. Welcome, everyone. Good morning, bon matin. Appreciate everyone being here after the Taylor Swift concert and a couple of days of conference already, and being a Saturday morning where you'd probably rather be in bed with coffee and croissants. So thank you. Just as you know, we're from Nova Scotia, and Dr. Martel and Julie had on their last slide their contact information. But if you're interested in staying in touch with us on any of the work that we're doing, so we have these 3 presentations this morning. I'll give a pitch. We have another one later this afternoon on our inpatient addiction medicine consult service. I have put a book and pen on the back table there if you wanted to add your name and contact information to stay in touch with us. We would we'll send you a note. So and how many people are or have been to Nova Scotia? Hands up. Oh, we really are Nova Scotia strong here, like Julie's
Close
previous
enough to the
slide.
mic.
Huh? Oh, my mic. I'm not in the right place. Sorry.
You want the portable one? You can do that too. Don't wander
We
too
might
far.
need one. Yeah, I'll see how I do. Tell me if you can't hear me. Sorry about that. So I'm probably sharing these pictures to kind of the converted of Nova Scotia lovers, but really kind of the point of showing a couple of pictures of Nova Scotia is really to show that, like most provinces in Canada, we really have a diverse landscape that has a lot of rurality. as well as some concentrated urban centers. And often there's very different concerns and challenges that are kind of dependent on those different kind of physical environments and the type of people who live and work and play in those environments. So as Dave mentioned, Dr. Martel, this project started way back in 2019, early 2019, before COVID. So we've been at it for a few years now. And as was mentioned, it's really trying to look at a provincial program of care, primarily at this point focused on withdrawal management support and early recovery support. Previously, why change? This is about is that we had different supports and services across Nova Scotia, primarily though for withdrawal management. It was inpatient withdrawal management only, and most aftercare supports were in community mental health and addictions, which didn't always meet the needs of the particular clients, and or there was a long wait for that type of service. So there was a lot of evolving evidence, which is kind of evidenced by the previous presentation. And, as well, similar to the opioid recovery programs and OUD treatment programs in Nova Scotia, we were looking to develop a more kind of integrated provincial program of care around withdrawal management and recovery supports. So those were our main change reasons. So what did we do? So again, this has taken us a long time, an embarrassing long time, some people would say. But we actually didn't have an off-the-shelf. We didn't know what to do. We didn't go in with a preconceived notion of this is what we're going to offer. We really took our time, like close to a year, working with the steering committee and an advisory group that had diverse representatives of people working in mental health and addictions, as well as people with lived and living experience and people from acute care and emergency departments. So we had a lot of folks guiding us, and then we did a lot of engagement as well. We also looked at the evidence, doing kind of literature review, jurisdictional scans, talked to all the teams, looked at a ton of data. So a very kind of intensive information gathering process. And then reviewing and assessing all that information that came in to help us kind of guide where we went. So after doing that for quite a long time, what we came up with was a piece of paper with this drawing on it, which was our vision. And our vision really literally was 8.5 by 11 piece of paper. And so this was towards the end of 2019. And, what we had learned from the evidence was that a lot of other people were looking at it too. There was change was in the air, and I think most people kind of would appreciate that. We found evidence that outpatient withdrawal management actually is very effective and safe for many, many people. And we weren't offering that very much in Nova Scotia. People were moving more from an abstinence-based approach to a harm reduction approach to care. The evidence was more supporting not a one type of treatment, but a multiple types of treatment options for clients depending on what they needed and where they were on their kind of journey. So, our goal was to develop a continuum of care, and this was our kind of first version with, I think as Dr. Mattel mentioned, this is an evolution, and we're hoping to kind of grow this over time. But essentially, it was meant to be very low barrier and accessible as well. So, and founded on what was going to be a new type of service in Nova Scotia, which are recovery support centers. And I don't know how to use that little pointer thing, but in the kind of the center big green box, we decided with no money that we were going to develop new recovery support centers across Nova Scotia. And then, through those recovery support centers, connect across a continuum of care of some existing services were already there and work to kind of grow our continuum and be very connected in terms of our referral sources, our accessibility, being very low barrier. we'll talk, Dr. Wenzel will talk a little bit more about what happens in a recovery support center in a second. But, so we just had started on this, we had our piece of paper and we were putting our working groups together to kind of develop it and everything, and then kind of COVID happened. So there was kind of a slowed down process for a little while, but we did forge ahead. And this is a bit of a status of where we are now in terms of our recovery support centers. We have, I don't know if you can see it very well, the little red ones are recovery support centers, and the yellow ones are inpatient withdrawal management. 3 of our inpatient withdrawal management centers are open, and 1 is not open right now. Most of the recovery support centers are open, but a few of them are not quite full service yet. So it, again, still kind of an evolution. And I'll hand it over to Dr. Wenzel to describe a little bit about what happens at the recovery support center.
Hello. So I've been asked to speak on it because it's my day-to-day work at this point. This is a picture of one of the newer sites that I think you said this was New Glasgow. Yeah. Just kind of showing the fact that there is like a team-based environment. It's meant to be a warm and welcoming environment as well. So I'm just going to speak quickly on what we actually do. So we have people who come to us from a variety of referrals. So basically they've tried to centralize the process as much as possible. So we do get referrals from central intake, or we can get referrals from a family doctor, from inpatient teams, or maybe they've just finished the inpatient withdrawal program, so they'd be coming over to us. And so the goal of that is to try and centralize everything so that the care is more universal. And so we do have an assessment that we do. So the client will meet with, whether it's like a social worker or a nurse, or sometimes even the physician, to go through some standardized questions to kind of get a picture of where they're at in their journey. So that can be whether we're focusing on harm reduction, or somebody's looking for abstinence-based supports. Perhaps someone is looking for groups. Perhaps somebody's being mandated to come to our services. So it's a snapshot that try to gather as much information we can around them, including things like mental health history, maybe treatments that they've tried before, what that look like, as well as any acute medical needs, because we do have a range of services that we kind of match people to. And sometimes it's not as clear as that, and then we have to have a further team discussion to really figure out where that person, including them, where they want to go next. So for the majority of people, if they're coming to us, we do have groups that we offer. Right now, in one of the ones that I'm at Dartmouth, we offer them 6 days a week. And the times do vary so that we can try and capture as many people as possible. And those go across 10 different modules, and it can be anything from what are cravings, coping with cravings, to leisure planning. So there's a whole wide array to try and capture interest in what people may be looking at, and as well as things like relapse prevention plans, those kinds of things. We also offer peer support, which I can't say enough about. That group is always highly attended, irregardless of what time it's put on. Very valuable service to the community. That is someone who has lived experience and meets with the people. We actually don't get to partake in those. As clinicians, it is meant to be those who are in living experience or lived experience to be able to meet, find a common ground, get support. And it's always a wonderful turnout, and we're really lucky to have that. And then we do have outpatient withdrawal as well located on that site. So that could be for things like alcohol use or cannabis use, stimulant use. There is a spectrum, and we do have exclusion criteria of what would be safe to be able to manage in the community. And so because of that, we do also collaborate a lot with our inpatient team. So if someone was to come in to us, maybe they were a walk-in, and they have alcohol use and they're asking for a withdrawal process, but they actually have a significant seizure history or very, very complex medical needs, then that may be someone that we communicate with the inpatient team and instead arrange transfer through to them. Ideally, it be something that we have happen seamlessly, but it's still a work in progress around that. So sometimes there can be a little bit of a wait or a lag time, but it has been getting better as the program rolls out. Um, and then the other big thing that we do serve there is that we do have the harm reduction lens as well. So we're trying to meet people where they're at, what they're interested in. So we do have some safe supplies, naloxone kits, as well as just that ability to meet one-on-one with a clinician to be able to talk about goals, where they're at, what does harm reduction look like for them? Are there steps that they can take to make things safer for them? Yeah, I'll speak to it later as well if there's any questions about specifics.
Thank you, Dr. Wenzel. I just want to add, I probably should have mentioned it before, like the recovery support centers as well are meant to be kind of very flexible in terms of their engagement with clients. There's no fixed duration, like it's not a 3-week program, a 6-week program. It really is kind of dependent on what the client needs, and they can come in and out of the program kind of as needed. And our group modules that we offer are primarily psychoeducation models based on kind of many of the common topics related to kind of substance use treatment. They're open groups. People can attend whichever modules they're interested in, or attend them, kind of participate in them kind of multiple times. So it's very flexible and doesn't have kind of a rigid approach. And this is some of the members from our Truro Recovery Support Center team. And so how do we do that? This was a question earlier as well about the OUD and ORP programs. How do we kind of shift practice? And it was actually a big change in Nova Scotia, shifting away from a largely abstinence-based approach in many settings to a more harm reduction, more flexible approach. One of the first things that started this work was previously we didn't really have an addictions lead at our leadership table within mental health and addiction. So a position was started with a physician lead addiction medicine, and our first PLAM, as we call them, was Dr. Sam Hickox. He's on the right there with the red ice cream. And then Dr. Martel followed after that when Dr. Hickox moved on to a different role at the provincial government. And this is them at the ISAM conference in Istanbul just recently. I don't know if they were working or just having a good time. We also really did, intentionally did some change management strategies, which Julie's group around ORP did as well, and really tried to shape the path for folks and make it easy for people. So having guidelines, having provincial forms, having pre-printed orders. So they're adding some structure as well, for the teams, but also to help kind of make it easy for them to kind of change. As well as we know there's some local needs that always needs to be adapted, and that's still a work in progress for us. We did some team education in key practice areas like trauma-informed care, motivational interviewing, group facilitation. So across the province, we did training for all the teams together. And some, just going to go back. Sorry, a few more change strategies. This is the New Glasgow team. We did provincial and team-based local orientation sessions that were recorded, and we did them as many times as needed to kind of reintroduce teams to kind of the process and the new model. We had a community of managers where they meet at least once a month. So previously, many of them didn't know each other. So we've developed kind of strong working together relationships with all the managers across the province, as well as other kind of key folks from quality and professional practice, those kinds of things. We did a lot of kind of promotional, we did develop patient pamphlets, promotional materials, brochures. So, really helped patients and the teams be clear about what is the purpose of the recovery support centers and the withdrawal management and other services, and how we all work together. We're at the tail end of the evaluation of kind of for this phase of the project. So we've been collecting administrative data. We've collected feedback from participants who attend groups. We did a very comprehensive questionnaire for each team to figure out what's working well, where do we need to improve, focus group managers, and we just completed some focus groups and surveys with clients. So we're just kind of wrapping up our final kind of information analysis. But we have some things to report already. So the first official recovery support center opened in Dartmouth in January 2022. The other ones, which we've been opening kind of, so there's been a staggered launch across the province. We were lucky through several financial requests to get more funding and money to kind of switch some teams over to the new model, but also to develop brand new sites and new teams that we previously didn't have. So it's been kind of a staggered launch. But in terms of, we've already kind of supported 3,300 clients, more than that, and over 27,000 visits. Am I running out of time? Probably. We had a great feedback from clients participating in the groups. A lot of them completed surveys and reported it very helpful and beneficial. We also had a lot of feedback of how we can improve from kind of the teams and the managers. So we knew we went into this not being perfect. We also knew we had to start somewhere and get going. And if we waited for perfect, we'd still be waiting. We want to shift more to some virtual care, enhance our group options. There's still, some process lack of clarity where we need to kind of solidify some of that, add more kind of leisure recreation support, do more outreach, especially to those kind of more vulnerable or kind of diverse populations. Kind of a bit of a gap, which has been a bit of a theme in this conference, is more support for people with co-occurring or concurrent disorders and some more team training. This is Dr. Martel's team in Lunenburg. That's Dr. Martel on the left, so he wears many, many hats within Nova Scotia. That's weird. Okay, we've had some challenges. I'll just, plus change. I don't know what happened there, but that's COVID, not Ovid. That's the philosophical version of COVID. A lot of change, and even though it was multi-year, it's a lot of change. And for folks, as many people, we have HHR challenges, including for prescribers, and that rural element, which we're still kind of working to kind of sort that out a little better. And our next steps is really just doing our evaluation report and kind of developing our recommendations for kind of our next work for improving. And this is the Dartmouth inpatient withdrawal management team of some of those folks. This is our leadership team for the managers of the withdrawal management and recovery support centers. We get together in person a few times a year and meet kind of at least monthly virtually. Thank you.
So as you could tell in all the photos that Lynn shared, when you go around and want to take a picture of a team, their willingness to stand next to each other is indicative of how well the team is functioning, I think, anyway. And you didn't see sour faces. And I think a big part of the success of a lot of the programming we're developing has to do with the efforts that we're putting into relationship building and these team dynamics. The same as Dr. Wenzel, I have a role in one of these recovery support centers. It's the main clinical work that I do, and it's a joy to try to appreciate the change that's taken place. I started doing this work in 2005, I think, it's a long time ago. And back then, I can remember that very rigid abstinence-based model, and we've evolved so far that we're now actually reaching the people that never got access to care. So we're going to open it up to comments, questions, if people want to share their experience.
What was that on timings? Oh, okay. I'll turn those off. I got it. Oh, did you advance it or did you?
No, I just pressed it. Yeah.
Criteria for participation. So could you just elaborate a little bit on that?
Yeah. Am I loud enough?
But
Come to the mic just because we're recording. Yeah.
Yeah, no, so great question. We have established exclusion criteria for what would be safe for someone to be able to likely participate in outpatient withdrawal versus inpatient. And so without looking at it directly, it basically, if it's an extreme situation, then they shouldn't probably be outpatient. So if they have known alcohol withdrawal seizures, and if there's someone with acute decompensated cirrhosis who may not be able to go home in the evening, if there's people with severe COPD with heart complications, perhaps it might not be safe to send them home with the medication. And we also do try and take a snapshot of what other medications they're on. So primarily, not only, but primarily if we're using those withdrawal scales and we're looking at treating it, historically that was always benzodiazepine focused, mainly diazepam. We are shifting that a bit again because some of the populations that we're serving may not need that level of withdrawal management. So we do kind of take a snapshot at, does someone have a safe, supportive place they're going home to in the evening? Do they have any support people? Because it's not an exclusion to not have someone, but it's great if they do. Is it someone who's already on, opioids and benzodiazepines or other medications that may be in combination too much for their system if it's not in a monitored setting? And so we kind of look at those things. I will say the one other big one that we've faced that is a newer challenge in the last few years, particularly with that population growth and things that we're seeing, is whether someone has safe housing to go to and be supported. Because if they don't, then more likely we may try and facilitate an inpatient stay. Often it's still kind of that 5 days for alcohol, maybe 7, just so that there are a pair of eyes there, supports there, just in the meantime.
The one thing I'll add is the word exclusion was put in there, and we were very deliberate about trying to envision this continuum of care in a way that was flexible. And what we put in place were labeled service level guidelines and really emphasizing the guidelines. And we're still kind of battling with, you don't belong here, you have to be in the hospital, or, you can do this from home. Trying to find a way to be flexible and to find a happy medium between people just booking a hotel room for their treatment, whether they needed it or not, wasting resources, creating wait lists, and being so rigid that people would just give up. We have to meet people where they are, and sometimes that means making decisions that you wouldn't normally make. And these guidelines help guide those decisions. Things like, how physically unwell are you? What's the risk of something bad happening? Because some of the settings that do withdrawal management still in Nova Scotia do so in isolation. They aren't necessarily in hospitals with ICUs. So we have to take a lot of these factors into consideration. Yeah, the question was, the rest of the recovery center is low barrier. The vision is that in addition to all this programming and these structures and protocols and service criteria, that we have something to offer people if they just knock on the door and wander in while we're open. Start the process of assessment and sorting, but more importantly, engagement. So barrier-free access is the goal. can only realistically do that well when the service runs every day of the week because of the way a withdrawal unfolds if you want to do it in a supervised way. There's a question in the back of the room.
Yeah, I was just wondering if, with part of the outpatient and the recovery support clinic, do you do groups with family members or significant others to invite them in to talk, to do psychoeducational groups along with the person? Is it done separately with the people or not yet? Or are you, what's the engagement there in order to help support them when they go home?
I'm going to punt this one to Lynn.
Thank you for that question. The question was whether or not we offer supports for affected others or family or friends of patients accessing the recovery support centers, or just who otherwise have people in their lives with substance use concerns. So currently we do not offer any direct group or direct one-to-one support for what we call in Nova Scotia affected others traditionally. It was originally part of our plan to kind of explore that prior to COVID, and it was one of the pieces that we, for better or worse, did not focus on as we had to, realize what can we realistically achieve through kind of the COVID years. What is offered is for folks, we have what's called what we call a brief intervention. So a brief intervention is where someone can come in, they don't receive or aren't interested in actually accessing our structured service, but they need some type of help or some kind of guidance. So we do find many people accessing that brief intervention support, which is with a clinician, typically a nurse or a social worker. That can be patients who aren't ready to engage as well, and maybe just looking for some safety planning or safer supplies, safer using supplies. But it is something that's been identified as a gap, and that we need to kind of further investigate in terms of what are the options of support for people in Nova Scotia as affected others. I don't know if that answers the question, but thank you. Any other questions?
Yeah, hi. Thank you. I really appreciate the presentation. It's really exciting to see you working on a whole population, really. But have you been able to incorporate metrics that look at recovery capital or progress over time, like the cascade of care, where you can look at your population and see mapping them and then looking to see where gaps are, and then ultimately, do they make progress towards wellness or recovery?
Fantastic question. In the interest of time, I'll field it. The entire mental health and addictions program in Nova Scotia has as some of its core mission to do measurement-based care. We started to incorporate these processes now some years ago into different elements of the mental health system. We have evaluation frameworks for programs. We have focus groups. The next speaker, I'm sure, will speak a lot to some of those processes. Trying to decide what is the best way to understand that we're getting value for money or that people are getting better is complicated. The system itself looks at, well, how many people are coming through the door. Instead of even looking at, well, are they getting any better? If you attended Brian Rush's talk in the afternoon yesterday, it was a lot of what his work has been over the past, I think he said 46 years, which I find amazing. But this is our mission, is to do much of that. Particular interest to me, and I've promoted it, is John Kelly's group, their BARC 10 tool. I love that tool. Because it speaks to social determinants of health. It's personalized. It's very, it's a conversation starter. It's something that really helps in many different ways, but it can also help us know that we're making a difference. But moving the very heavy barge incrementally towards something different is, the myth of Sisyphus he quoted yesterday, and it'll come up again and again. So thank you for your question.
Hi there.
Last question, then we have to move on. It should be yes or no.
No pressure. In our community in Northwestern Ontario, we're facing a huge, and I'm sure most of the country's experiencing this huge homeless population. But what I am finding is, especially from an inpatient perspective, and even talking to our clinics in the community, that the homelessness is often a barrier either to discharge or to manage. I'm wondering how often is that a care to keeping people in an outpatient where you're having to admit people simply out of lack of safe place for them to be able to detox?
Some of these places, it's the biggest problem and the biggest barrier. We do the best we can, and I think we face this across the country. Yeah. I was just going to say yes, and then just leave it at that. Yeah.
Capture data and report it.
So we're going to move on. We have about a half hour left, and I plan to stick around after the session. Thank you, Jessica and Lynn, for that presentation. Our last session, I'm going to contribute to it as best I can. I've been forewarned that there's part of it that involves me doing some interpretive dance, which now that I know this is being recorded, I will not do. Yeah, no evidence. The speakers are mostly Janelle Comeau, and I plan to just kind of be a cheerleader. Janelle and I have just started to work together over the past few months, and largely based on the things she's going to talk about, which involve the gnashing of teeth and angst and raised blood pressure of making a system that traditionally hasn't embraced all the tenets of harm reduction to do the work that we should have already been doing for many years. It's building a harm reduction policy for the province. Janelle?
Thanks. Oh, thank you.
Good morning, everyone. Bonjour, bon matin for all you fellow francophones in the room, if there's any. I hope I'm not the only one. Good morning and welcome to Challenges Along the Path to Creating a Harm Reduction Policy at Nova Scotia Health. And we're going to share a lot of the challenges, but also a lot of the good things that happened because they both kind of go hand in hand. So my name's Janelle Comeau, and I'm a registered master's in social work. And my current role, though I've worked in mental health for the majority of my career at Nova Scotia Health, currently I'm working for the Interprofessional Practice and Learning Service at Nova Scotia Health as the Mental Health and Addictions Provincial Professional Lead to work with the Mental Health and Addictions Program around policy creation, around model of care reviews, and all those kinds of wonderful things. And I get to partner with the wonderful dancer next to me, who's already introduced himself. And today we'll take you through the complex journey of creating a harm reduction policy at Nova Scotia Health. We'll emphasize some of the journey highlights, because there were some, and the importance of collaboration, research, and navigating healthcare bureaucracy. Dave and I think I can speak for you, you're not very conflict of interest-y. We do not have conflicts of interest. So at Nova Scotia Health, ironically enough, or maybe not, there was an absence of a formal harm reduction policy, despite the ongoing demand for clear guidance. There were so many tensions that were bubbling up across the organization, such as the need to address legal considerations and protections and clear practice parameters, as raised by many concerned parties, such as the Canadian Nurses Protective Society and the Nova Scotia College of Nurses. Nova Scotia Health was actually experiencing work refusals by nursing teams as they were being advised by CNPS and NSCN to think carefully about performing any type of harm reduction interventions in the absence of an employer policy on the same. So every day my department was receiving calls from managers and directors and nurses themselves who were refusing to practice harm reduction interventions and who were experiencing tons of moral residue or moral issues, standoffs with themselves and with their employer around wanting to practice some of these interventions. We were hearing about all kinds of patient safety and staff safety situation issues across Nova Scotia Health that would have benefited from a clear policy direction on harm reduction. And we were also watching the number of deaths climb in the province due to substance use disorder that could have possibly been prevented if Nova Scotia Health had some clear policy direction. So I mentioned we were receiving concerns from parties around this lack of harm reduction policy. So we had diverse groups whose roles, concerns, and practices impact harm reduction were asking us for guidance everywhere they could. And many of them were landing with my service and with the Inpatient Addiction Medicine Consult Service. So we joined forces to work together to respond. Concerns groups included frontline staff who were like, I don't know what I'm allowed to do every day when I come to work. And then we had managers and directors who were like, I don't know, can I ask my staff to do this? Am I allowed? Does the employer sanction these? If I performance manage, if they're not doing it, will the organization support me? What do patients want us to do? There were so many questions happening. And at the same time, we were hearing from patients and families that we were quite behind the times and that patients were moving across our province and they were getting harm reduction interventions in one area of the province, and then they'd move to another one and they'd say, oh, that's not allowed here. And they were like, well, wait a minute, isn't this all Nova Scotia Health? So there was lots of differences in equitable service provision across the province. Allied health regulatory bodies in Nova Scotia and the College of Physicians and Surgeons had statements in place that supported harm reduction principles and interventions for their membership, but the College of Nurses in Nova Scotia did not. The lack of Nova Scotia health policy was also creating strain on the already limited resources in the community organizations that were providing harm reduction intervention, for example, the provision of sterile supplies, safe consumption sites, etc. So because we didn't have any of these interventions clearly locked down as allowable interventions in policy, we were forcing our often poorer community organizations to handle all of the demand and foot the bill. Oop, I'm going ahead of myself. So when I started in this role about 2 years ago, I was being overwhelmingly contacted on this particular topic. We already had a place to start when we started engaging people to find out what we needed to add in this policy, because we were being given all kinds of concerns, questions, intervention requests. We were having so much engagement about it, actually, that we said, oh my God, like we have to do something. We have to put a policy in place. We had all kinds of calls, emails, reach outs, all kinds of documented questions that helped us to initiate that broader policy development and direction. And in order to get this right and support the similar and varying needs across programs, there was a highlighted importance, not surprisingly, to address these concerns systemically through research-led policy creation. So we started to look at cross-jurisdictional policy and best practice across Canada and in other jurisdictions, probably and likely from some of your organizations represented here today. So thank you for the work you did ahead of us. And we were able to start seeing some ways forward and some recommendations to make around allowable interventions. As part of this process, though, we quickly realized that some of the items we were wanting to list as potential interventions would require a consult with the Nova Scotia Health legal team. So we wrote a briefing note that identified critical issues in patient safety, ethical concerns, and scope of practice. We also summarized best practice and national policy trends on these interventions. And we recommended 9 interventions for sanctioning and asked the Nova Scotia legal team to clarify actionable items. And then we waited. And waited, and waited. But the concerns kept coming to us via email, phone, or Teams meetings, so I complained. The line at the bottom of the screen there is me. So I let Dave know that I was going to crankosaurus up a bit, to use my grandson's language, and I ran to the vice presidents of mental health and addictions, public health, and interprofessional practice and said, could you please push legal? People are dying. And so we did, and they did. So when the legal team finally provided us with their response, after being strongly nudged, they categorized the interventions. So we celebrated because that's where Dave was supposed to dance.
That's absolutely perfect for the end of the symposium. We're going to use that next year too.
Oh my God, I scared the crap out of myself. So, so the legal team categorized the interventions that we recommended in green as, yeah, you go, good to include. Yellow was like, you might need to think about it, or you may need some further evidence or further approval. And red light ones, which were like, you're going to need national approval for this or higher level approval, so think a bit more on it. And once we received this document, we decided to meet with the vice presidents of public health, mental health, and IPPNL, as well as senior directors, the provincial psychiatry lead, the Dave, as well as representatives from the legal team. And they provided us with overwhelming support, hence the celebrate good time. I'm a dancer, so music is so much my thing. And we were like, oh my God, this is going so well. Like, we're going to get this approved in very little time. Like, I don't know if any of you work in policy. I do. It takes years. Like, this was like months in the making. So I was so happy. So we did a little celebration dance, and we were like, look at us. We're unstoppable. Or so we thought. The whole way. I've got more music, and it's probably going to scare us all. So after the celebration dance, we set ourselves to drafting the first phase of the policy. This phase would include education and counseling as its own intervention, but also as part of all other sanctioned interventions. Can't just give out sterile supplies without educating and talking about it. The provision of sterile supplies, such as sterile needles, syringes, sharp containers, safe for smoking, and other drug preparation and injecting equipment. For example, but not limited to filters, cookers, sterile water, sorbic acid, tourniquets, etc. To reduce the risk of death and bloodborne infections such as HIV and HEP among people who use drugs. Medications such as methadone, bupe, naloxone, sustained release oral morphine, and nicotine replacement therapy, as well as the risk of opioid poisoning and substance use related harm, a protocol for the use and the support of injectable OAT and other short-acting opioid agonist medications, including hydromorphone, when required. Expanding access to OAT for opioid use disorder and other substance use disorders, including medications like naltrexone, acamprosate, naloxone, and also providing safer sex supplies, etc. We also wanted to provide Indigenous populations with sexual health medicine bundles, which may include traditional healing supplies. And also we provided for the accessing and providing of pre-exposure prophylaxis and post-exposure prophylaxis. But we also wanted to nestle this policy in some guiding principles and key considerations. So we also wanted to set that right tone. These guiding principles help to shape and anchor the policy, clarity, finally, for people who worked in our system around what interventions were being sanctioned at present, what harm reduction means within the context of Nova Scotia Health, and what the role of our senior leadership, our management, and our team members will be vis-a-vis the policy. We wanted this policy to provide consistency with respect to the interventions. So if you lived in Sydney, Nova Scotia, or if you lived in Yarmouth, you should be able to benefit from the same harm reduction interventions that you clinically require for your disposition. And we wanted to provide equity in the sense that the stigma of substance use, homelessness, and what may be considered as sexual behaviors that may pose risks and may cause harm is exacerbated for people intersecting marginalized identities, including, but not limited to, people who are Black, African Nova Scotians, Mi'kmaq, Indigenous, Acadian, Francophone, racialized, who have disabilities, and members of 2S LGBTQIA+ communities. And we also wanted to embrace patient-centered care and work on some safety components to win back the trust of people with lived and living experience, and also be trauma informed as a determinant of health. I'm going to jump. You can see there's a But when we were navigating the bureaucratic pathways, as anyone tries to create and implement policy across system knows, this process has been rife with wins, setbacks, and downright frustrations. When you're looking at large, complex provincial organizations such as Nova Scotia Health, you're dealing with the complexities of healthcare bureaucracy. And there's some good to that. Bureaucracy provides us with checks and balances to keep us all safe. But there are places where we can do better. We did work with people with lived and living experience and with equity-seeking groups around providing us feedback for this policy. But the vice presidents had told us to get this policy ready in 2 weeks or less. So when you're trying to get equity-seeking groups to comment and PWLLEs to comment on things and you say, you've got 3 days turnaround time, it doesn't feel very respectful. And as a member of an equity-seeking group myself, I often find that smacks of tokenism and wonderful stuff like that. But at least we did some research, reach out to them. But this is a first phase policy. And along the way, we're going to continue to reach out with better timelines. We also had many grenades, and I mean grenades, thrown to us along the way, like stigma-based thinking within the organization. Either stigma-based thinking about people with lived and living experience or concern that if we had a policy like this, it might affect the organization's public image and reputation. There's lack of understanding and education and misconceptions about harm reduction, such as it enables substance use, or not knowing that as an organization, we were already providing all of these interventions. There were legal and regulatory concerns, concerns about potential legal liabilities, and, then there was those short timelines they gave us. They said, yeah, we want this, write it in 2 weeks or less. And then we would. So we had to really be tenacious when we were dealing with these grenades. We really, whenever we got knocked down, we had to get up again. It sort of became the theme song around wanting to push this forward. Like, we can't give up no matter the grenades that were being thrown at us. So, the COC, or the Clinical Operations Council, said, you're approved, you have 2 weeks to write it. So we wrote it in 2 weeks and we sent it to them. And guess what? We waited and waited and waited. And then sometime in late September, they said, we're going live on October 15th. Like, they told us that on September 30th. And we were like, okay, but do you know what bringing a policy like this live to an entire provincial health authority is like? You need education, you need a memo, okay. So we started busting our derrieres to get this done by October 15th. And so we started working on the above, but there was a delay in policy rollout. So at the 11th hour, we were told, no, we're not going live. We need to have further conversations with the Council of Unions and the Nova Scotia Department of Health and Wellness and the Nova Scotia Office of Addictions and Mental Health. And we were like, okay, well, we get that. Good to dot I's, cross T's, all that kind of stuff. And it also gave us more time to put a comms plan in place and an implementation plan around training and all that kind of stuff. So we were like, okay, no problem. But what we didn't know was that there was a more nefarious plot afoot. A provincial election. And listen, I'm probably more pro-democracy and pro-voting rights than, the average Joe. But when it interferes with policy development that could actually save people's lives and, provide people's ability to work and not live in continuous moral residue, it makes me a little cranky. I'm still going to vote because I believe we need to exercise that right, but I am cranky about it. So we're being told we're launching the first week of December because the provincial election is November 26th. So, and they know, like our VPs know that they can launch the cannons if there's not action. And the cannons are also known as Dave and Janelle. We're the cannons. So they know to launch us if things don't start to move, so we can turn our cranky selves into good advocates. Well, not that cranky. So in the meantime, we're going to create those comms tools and those implementation tools. And some of the comms tools that we're working on is we've created a memo to be rolled out to the entirety of Nova Scotia Health, announcing the policy and its inclusions and inviting people to attend virtual subject matter expert sessions. We created a dedicated support email to call harmreduction@nshealth.ca, where staff will be able to ask us questions and a team of us will funnel them to the right people for answers. And we've created a working group for continuous education, and likely that continuous education will be largely influenced by what we get through those email chains. So again, the cry to be tenacious if you're doing these kinds of things. So, and we're also creating some FAQs, monthly education offerings, and some one-pager info sheets to help with this. So the next step and the path forward is we're going to keep being tenacious. Every time we get knocked down, we'll get up again. And, you know, we will be launching this after the election, even if it's with a new government. And we're working towards the approval of the phase 2 interventions, which are safe consumption sites and episodic protocols for rural areas, as well as drug checking and surveillance parameters. And we'll keep pushing forward despite the fear of a federal election and what this could mean to exemptions, et cetera, to the Narcotics Act. So continue implementation no matter what is our plan. And so if you're starting to do this, I guess my best advice would be if you get knocked down, get up again and just keep pushing forward. So I don't know if you have any, Dave and I like cats, just like real cats. So that's why I put that there for you guys if you have any questions.
Thank you, Janelle. And being mindful that we are at time and butting up against a break, for those of you who need to leave to top up your caffeine lull, please do. We're going to stick around after the session to field questions. We're happy to take them in the moment too, but if you'd like to use the washroom, please do. I want to say thank you to the team for putting this symposium together. You know, these are my people. This was a lot of fun. Yeah. So lucky to live where we live and to get to work with all of you is fantastic. Questions? Anybody have questions? Anybody getting knocked down actively where they're trying to develop harm reduction policy? Oh, definitely. Yeah. The speaker. I can repeat the question.
Hi. Sorry, I missed like half of the talk, so my question might be partially irrelevant. I'm from London, and our hospital is actively trying to set up a harm reduction policy, also on a very tight / unrealistic timeline. I'm just curious, and like again, I might have just missed it. I noted that you kind of mentioned that your policy is broken up into a few different phases, and I'm wondering how you decided what goes into which phase and what is phase 1, because like in London we have this policy that's informed by an advisory committee with like 100 recommendations that are all lovely and great. And when I sit on the board, no one seems to understand how addictions care actually works. So it's just very tough.
A very good question. And I'm gonna look at my partner and say, well, what are we doing next? Like, how are we doing this? But I'll start with what's a Catholic hospital? Like, it's a, you know, what you're going to face, I think, across the country is just differences in the way that things are structured. Um, I could comment, and maybe we'll talk afterwards about my journey through medical assistance in dying implementation in Nova Scotia. But Janelle, what are we doing?
So we did a cross-jurisdictional search to see what best practice that other kind of hospitals across the country and across the globe really were doing as first line sort of policy interventions. And then we engaged with our legal team to help us understand what could we approve on our own as a health authority and what other interventions that we need to go and get higher level approvals. So our legal team codified the 9 interventions that we had recommended into green light, yellow light, and red light items. And the green light items were, like there's tons of evidence that this is happening in other healthcare jurisdictions. You're safe to go. And then the yellow light were like, you might need a bit more, but the ironic thing was when we looked at the yellow light ones, we were already doing them.
And some of us who are a little colorblind, our yellow was greenish yellow.
So when we decided to write the policy, we forgot about the yellow-green distinction and we put them both in. So because we knew we were already doing them, like one of the yellow light items was the provision of oat. Like we'd been doing that for a long time. So we were like, come on, legal team. So the red light items were the ones that really require sort of those national exemptions. So that's why we're phasing it. And so that's kind of that's how we chose to go forward. Could our legal team and what was needed to help provide clarity to what was the most common themes we heard all the time, and some of the most common themes were even around the sterile supplies. Like people were going to our procurement people to order, sterile supplies, and they were being told, you can't have that. So it was like extremely bad. You would think those would come naturally in a hospital world, but they did not. So that's how we decided which ones were the ones we could get through legally initially first, and which ones we'd need to go higher for approvals.
Sorry, if I could ask just one more question, if everyone's okay with that.
And as Janelle had indicated earlier, like the red were red because they require CDSA exemptions.
Yeah, and that totally makes sense. One of the other issues we're kind of running into is the hospital in London is massive, and they're siloing within the hospital. So there's kind of a push to do things in certain departments rather than others, which I think then like disadvantages my the psychiatry department is more easy to do certain things in, mainly because there's board members that are on this committee that are in psych, and then I'm kind of in the medicine world, and my patients don't already get a lot of those things, and then now we're going to not get them again. And I just wonder, like, is that something you ran into where like certain portions or certain hospitals within the authority were more willing to do things, and if you went ahead and just did it anyways everywhere, or you broke it up in parts?
We're at the beginning,
Yeah.
But the answer is yes.
Okay.
Yeah.
Cool. Thank you.
Yeah, and even within hospitals, we were seeing, differences on floors between what was being allowed and not allowed from a harm reduction point of view. I think, one of the suggestions that I might have, like, I don't know if you have an interprofessional practice and learning kind of group within your hospital. We are allowed to get away with stuff that sometimes other services can't do because we're kind of that neutral sort of, party, and we can push things and bring people together. Not that programs can't do that, but we span the entirety of Nova Scotia health system. So if you've got those folks in your world, I would suggest partnering up. Like we really can push agendas that others can't sometimes.
Amazing. Thank you so much.
The last thing I'll add, of course, is once you have a policy in place, we're fortunate we have one health authority. We don't have to herd a lot of cats. We got one cat. My cat's name is Hugo, by the way.
I have 4 of them.
Yeah. But once this becomes a policy, it's not a matter of, what do you guys think? You want to do some of this stuff? It's, you're going to be held accountable for these things, and then it comes down to leadership, and senior level leadership, ensuring that the things that are written into policy are followed. So it's kind of from above rather than pushing from below. And I think it becomes an organizational thing, and the cultures slowly shift. They're nudged, maybe probably through attrition. That's my guess. Yeah.
Amazing. Thank you.
Yeah, the last thing I'll say is like the communication is coming from the highest level of Nova Scotia Health to launch this, right? And in the policy, it's clearly indicated the role that senior leadership has to play in supporting the rollout of this. So those are, I think, key pieces to this as well, to ensuring that it's taken up by the entire organization, not just by those who wish to.
Thank you.
Thank you, merci.
Thank you for coming.